Looks like we've got a lot of alum with us here today. That's awesome. Welcome, everybody. Today, we are really excited to be featuring Michigan social work alum Bruce Thayer. Bruce is a distinguished research professor of social work at Florida State University. He received his PhD in social work and psychology from the University of Michigan in 1982. He is a licensed social worker in Georgia and Florida and a board certified behavior analyst. He has published extensively in the areas of treating people with anxiety disorders, evidence based practice, clinical social work theory, and evaluation research. So we are now going to pass things on to Bruce.
Hello, everybody. Shall I go ahead, Emma?
Yeah, you are good to go.
Okay. Good afternoon. It's just at noon here in Tallahassee, Florida, where it's 80 degrees, and I'm wearing my University of Michigan Hawaiian shirt, one of my favorite garbs. Appreciate you taking time out of your busy schedule to attend this session, which will be focused on how to help clients with real-life exposure therapy. Next slide. Alternative title, everything you want to know about phobia is what we're afraid to ask. Next slide. I learned about real-life exposure therapy when I was a second-year MSW intern with University of Georgia Psychology Clinic. I worked with a severely height-phobic woman and for about 3 months, and this culminated with a successful trip to the Windows of the World, which was a restaurant atop the World Trade Center before it got destroyed. It was remarkably successful treatment for a condition she had all of her adult life, and it really made an impression on me about how powerful the method happened to be. She was just not up there with me, but she was actually calm. So I had a little bit of background doing some exposure therapy, and after my MSW, I began the Michigan PhD program, and I chose social work and psychology. Next slide. About 6 months after starting the Michigan program, I attended a continuing ed workshop led by a psychiatrist from the Department of Psychiatry at the U of M. His name was George Curtis, and he ran what was then called a Phobia clinic, where they were recruiting people with clinical anxiety disorders for research purposes, and as an inducement to participate in research, they offered them free treatment. And after his presentation, I went up to him and introduced myself, told him I had some experience in doing exposure, which was primarily what they did, and I was interested in perhaps going to work for them part-time. And the upshot was a couple months later, I did. I started part-time, $15 an hour. So if I saw 5 hours worth of clients, I got paid $75. And after a year or so, the caseload was such that I moved to half-time with benefits, which was quite nice. And then full-time with benefits. I got my PhD, and in 82, worked for several more years full-time in the anxiety disorders program, as the name was changed, doing individual and group therapy with people with different types of anxiety disorders across the spectrum. So I got my clinical hours during my doctoral program for several years afterwards. And then I left Ann Arbor in 84 to come to Florida State for a few years. Then I went back to Georgia for 15 years, came back here to Florida State in 2002, where I remain on the faculty. And as Emma said, I'm an LCSW and in 2 states, and also a board certified behavior analyst. Next slide, please. I've had a small private practice in Tallahassee and later briefly in Buckhead, Atlanta, Georgia. And I've written extensively about exposure therapy for phobic clients over the years, beginning in 1980s, and still do so. Next slide, please. So here you can see one of my very earliest publications titled Prolonged Exposure Therapy with a 70-year-old Woman. And I completed this case while I was working in the anxiety disorders program, and it was very successful. And I was able to publish it in a decent psychiatric journal. And then some other works, I published an article called Treating Anxiety Disorders with Exposure Therapy and Social Casework in 83, and another one, Fainting on Exposure to Phobic Stimuli in the American Journal of Psychiatry. And then up to this past year, I've had several references in the Social Workers Desk reference on treating social anxiety disorder and also specific phobias, and many, many, many other publications in the broad area of anxiety disorders. It's an interest that has stuck with me, and I'm continuing to clinically consult with folks about this. Next slide, please. So when may exposure therapy be useful? It's often useful for clients who meet the DSM criteria for some of the anxiety disorders, as well as obsessive compulsive disorders, and a number of other conditions that I won't go into today. The focus today will be on assessment and treatment of clients who meet the criteria for either specific phobia, social phobia, OCD, PTSD, and agoraphobia, and panic attacks. Next slide, please. So I'm working from the DSM-5. The TR came out more recently. Not a lot of substantive changes with the anxiety disorders. And this is a list of what the 5 contain about the different conditions that they labeled under anxiety disorders. OCD was removed and now is a different category. Next slide, please. So let's start simple with what's a specific phobia? Next slide. This is a fear that's marked and out of proportion in the presence of an environmental or situational context, or the person is anticipating such exposure to a specific object or situation. Think of things like dogs and cats and snakes, small spaces, the dark, bugs, birds, bees, heights, anything that's situationally specific. And when the person is exposed to what they're afraid of, let's say a dog, this exposure provokes immediate distress and severe anxiety. And the avoidance and the anxious anticipation or distress in the feared situation actually interferes with the person's normal routine. It does say child here, but it's all clients. Their normal routine, their work functioning, social relationships, and so forth. And the symptoms must have lasted about 6 months. These are very common specific phobias. Next slide, please. More specifics. I mentioned here heights is another type of common specific phobia, seeing blood or receiving an injection. The object or situation is actively avoided, or if you can't avoid it, you endure it with intense fear and anxiety. And the fear and anxiety is out of proportion to the actual danger involved in the situation or to the socio-cultural context. Lots of us would be afraid of a very loud barking pit bull that was running at us. It would not be out of proportion to be afraid of that. But if you have a similar level of fear to a small puppy that's on a leash 10 feet away, and it really interferes with your ability to get along, then that would likely be seen as out of proportion to the circumstances. Next slide, please. The fear anxiety has to last a while and causes impairment, and it's not better explained by another condition like OCD or PTSD or something like that. Those would trump the diagnoses of specific phobia. Next slide. There are some specifiers to the criteria. You can have an animal type phobia, a natural environment. This would be like bees or small enclosed spaces, what could be called claustrophobia, fear of the dark. Blood injury and injection phobia, that's not uncommon at all. Other types of situations, and some other odd things like fear of choking or vomiting, and sometimes in children, loud noises or costume characters. Multiple phobias are common. Most onsets appear to be in the early childhood of folks who have a specific phobia, but in many cases, the precipitating event or etiology remains unknown, even after your best methods of assessment. Next slide, please. So what are some of the causes of specific phobias? Part of them seem to be attributable to some type of conditioning experience. They've had a direct experience to something that made them very, very frightened. The criteria up here say real danger, but it doesn't necessarily have to be. Like I know a woman who developed a severe fear of a phobia of noises and balloons when she was a young child and somebody popped a balloon behind her back unexpectedly. And prior to that point, she had no fear of balloons or of loud noises. And after that, she had both. Sometimes one can have a vicarious experience, observing somebody else display fear or panic in a situation. The woman I worked with who had a severe fear of heights, she had a mother who had a severe fear of heights and role modeled that type of behavior throughout my client's life. and she was constantly being warned, not to get close to edges and things like that. Another can be being told about a danger. Some people got really frightened about COVID transmission and fear of germ transmission, for example. They haven't had COVID. They don't know of anybody who's had COVID, but they've learned that something is said to be very dangerous. So it could be germs, or if you're told that you can get shocked from using a particular type of electrical device, you might get frightened of that. There have been lots of retrospective studies where I talk to people with different types of anxiety disorders and ask them, what's your best recollection of how it began and when it began? So there's a whole huge literature on the descriptive psychopathology of these things. The etiology really doesn't appear to matter, whether you had a frightening experience yourself, or you watch somebody else have a frightening experience, or whether you're told about something that you've taken to heart and you're afraid of it now. It's all treated pretty much the same way. Next slide, please. Very common lifetime prevalence of specific phobia is estimated to be over 12% in the general population. So if we've got 117 participants in this session now, we probably got 15 to 20 folks that actually have had, or may have had, or will have a specific phobia. Next slide, please. Looking at other statistics, social phobia is also very common. PTSD, GAD, panic, OCD, they're not rare. And if you have a practice and become known for treating people with anxiety disorders, you'll have plenty of people knocking on your door seeking some assistance if you can genuinely help them. So takeaway here, anxiety disorder is one of the more common of the DSM conditions. Next slide, please. The approach that I'm talking about today is called exposure therapy, and there's many historical anecdotes of people overcoming their fears by facing them. The German writer Goethe was said to overcome his fear of heights by climbing into the church clock tower and emerging out on the little tiny balcony. And sorry about that. Turn my sound off. And just standing there for hours overlooking the town, and he was just terrified, and he remained there. He forced himself to stay there. And after a few hours, he calmed down and he found that his fear of heights was greatly weakened. Even Freud and Jung used some variations of exposure therapy in their work, not a lot, but some. And they came up with a psychodynamic process called abreaction. It's the kind of overwhelming emotional response you have when you encounter a frightening situation or some recollection that was very troubling. Next slide, please. Also related to the psychodynamic concept of catharsis. And sometimes my psychodynamic colleagues would try and explain how exposure therapy works as some variation of the psychodynamic mechanisms of abreaction or catharsis. But most people who write about it usually view exposure therapy as being helpful because of some process more related to learning theory, without referring to the unconscious processes of Freud and other psychodynamic theorists. Next slide, please. A big breakthrough came in the treatment of anxiety disorders in the mid-'80s, when a South African psychiatrist named Joseph Wolpe published a book, which was actually the first treatment manual for a psychotherapy. And his approach was called systematic desensitization. And he developed this in South Africa, then he immigrated to the US to Stanford University. And he described his approach, which was to work with a phobic client and have them create, with the therapist, a hierarchy of imaginal exposure to feared situations. If it was a fear of a dog, it'd be looking at a small puppy from 10 feet away, and go on up to more and more frightening things, a bigger dog, a barking dog, several dogs, closer involvement, and so forth. So you sort of have this sort of laid out. Therapist has it on like a little list, and then the therapist trains the client in engaging in something called progressive muscular relaxation. This has been around for a long, long time, and it involves the client under the therapist's direction while lying on a couch, alternately tensing up, holding, and then relaxing different muscle groups, maybe starting with your wrist, then your forearm, then your upper arm. You hold it for a while, tight, 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 and then you relax all at once. And the therapist walks you through your whole body doing this. And when you're done, it takes about 45 minutes, and you're laying there and you're pretty much feeling like a wrung out dish rag. You're pretty relaxed lying there. So now you're relaxed. Wolpe's got your imaginal hierarchy. And what he does is he asks you to try and imagine with your eyes closed, your lowest item on the hierarchy, the puppy from 10 feet away tied to a leash. And if you experience anxiety, as you're lying there, let's say your hands are on your chest or your stomach, you lift your little finger, or you're saying, I'm getting nervous. And then he would say, okay, stop thinking about the little puppy, go back to your happy place, enjoy your relaxation. And he'd maintain you in that state for a few minutes, then bring you back to thinking about the lowest item on the fear hierarchy. And this would continue until the person could contemplate the lowest item on their hierarchy without discomfort. Then they go to the next item and so forth. This worked reasonably well. They'd slowly work up the hierarchy, and then in between sessions, which would last an hour or two, Wolpe would go and encourage them to go and practice what they were doing in imagination in the consulting room. So you slowly work your way up the hierarchy, and you're practicing in between. And when you can accomplish in imagination everything that you were really terrified of, it hoped that this would generalize into real life. And after Wolpe did his book, Psychotherapy by Reciprocal Inhibition, the treatment manual for systematic desensitization, lots of people began doing it, and then lots of people began doing well-controlled experimental studies testing it. We go to the next slide, please. Wolpe hypothesized that the mechanism of action of systematic desensitization was a process he called reciprocal inhibition. And this is based on the idea that a nerve can't be alternately sending the message, be afraid, at the same time it's conveying the message, be relaxed, be relaxed. So by pairing deep relaxation with very mildly anxiety-evoking scenes of imagination, it was hoped that the relaxation message would sort of counteract the anxiety message. And by doing this for a prolonged period of time, this was shown to be the case. People could work through their hierarchy, and it turned out that systematic desensitization actually did work pretty well. And there are many well-controlled studies about it. And it was also slow and tedious. I've done it many times in my early years training, and it's nice to be able to work with something that works reasonably well, but nobody wants to be bored while they're doing therapy. So people fortunately began to investigate the mechanism of action of systematic desensitization. Could we have the next slide, please? Wolpe said it was reciprocal inhibition, and research began dissecting the critical elements of systematic desensitization with controlled experiments. For example, they would have some people randomly assigned to get the complete package of systematic desensitization, and the other people would get it without relaxation training. They would just create the hierarchy, they'd lie on the sofa with no formal relaxation training, and just proceed up the hierarchy. That worked. It worked just as well as did systematic desensitization with relaxation training. Then they thought, is it necessary to start at the bottom of the hierarchy? Let's try and do from the top down. So they would randomly assign people with phobias to get traditional systematic desensitization. And then the other group would get it where you'd start at the most anxiety-evoking situation. And this was a little more rigorous, but it was shown that when you did it, it didn't matter whether you went up the hierarchy or down the hierarchy, improvements ultimately remained the same. So those two findings, the hierarchy doesn't matter and relaxation training doesn't matter, sort of discounted the idea that it was reciprocal inhibition, Wolpe's neurological theory, that caused the effects of systematic desensitization. Further studies began to be done, and they wanted to isolate the role of real-life exposure that patients were supposed to engage in between their sessions in the office with the therapist. And so they began doing studies where half the patients got real systematic desensitization and then specific advice and encouragement to go out and try and confront what they are afraid of in real life in a manner similar to what they'd done in imagination in the office. The other half were randomly assigned to systematic desensitization, and they were specifically told, avoid confronting what you're afraid of. Don't engage in any explicit practice. Stay away from it. Just come into the office and we'll treat you here, and that's it. And when they did this, they found out, lo and behold, the people who had avoidance instructions, don't expose yourself in real life at all, didn't make much progress. Whereas the people who got systematic desensitization with real life exposure did. So then that led folks to think, okay, let's compare deliberate real life exposure in a hierarchy in real life to systematic desensitization in the office, paired with relaxation training and so forth. And they found that if they did real life exposure, it worked better than imaginal systematic desensitization in the office. And this was a big breakthrough. It was fairly clear by the early 70s that real life exposure therapy could be immensely therapeutic when it was properly undertaken. We have the next slide, please. So next one. You're going backwards. So by the late 70s, nope. Go back one, please.
Sorry, are we on the right one?
Yeah, minimize the poll question.
Okay, since it's up, let's go ahead and let people just respond really quick, and you can keep talking if you want.
Sure, okay. So by the late 1970s, systematic desensitization in imagination had largely been replaced by the more parsimonious procedure of real-life exposure therapy, with exposure in imagination or in virtual reality contexts, or with different types of substitutes like rubber snakes or toy dogs or something like that, would be reserved for difficult to recreate phobic situations, or for patients who simply refused any exposure to what they're afraid of in real life. So now systematic desensitization is still a decent treatment, but it's rarely done, except perhaps by people in private practice for whom time is not too important. You don't want to get the people that well that quickly, because that would impact your fees. So next slide, please, which I think is the whole question.
Okay, so if you have not already responded to the poll, please go ahead and do so now. And you'll see that Bruce has put on the slides that you can use the thumbs up or thumbs down reaction icons. So that's always fun to see those pop up if you guys want to participate that way. Nice. And if the poll function isn't working for you, go ahead and put your response in the chat. I'm going to go ahead and end the poll and share those results out.
Well, the correct answer was true. Yeah, that's what Wolpe said. His proposed mechanism was reciprocal inhibition, but we're pretty sure that's not the case now. Can we go to the next slide, please? So let me skip this one. I got a lot of content to go through. Next slide. When a person confronts what they're afraid of, a dog, a cat, a snake, or small enclosed room, a bug, something like that, anxiety can be graphed along the lines of this slide that we see here, with anxiety on the vertical axis, high versus low, and then exposure could be perhaps distance to what you're afraid of, so that when you're very close to what you're afraid of, your anxiety spikes. But what people don't realize is that if what they're confronting is not inherently dangerous, then the anxiety is going to go down on its own. It feels very uncomfortable initially, and most people's response is to leave the situation. They'll get away from the dog, they'll leave the small space, they'll spray the bug or something like that, and they feel better when they do that. But the kicker would have been if they had simply stayed there, and if nothing bad had happened, the dog hadn't attacked you, or you weren't bitten by the snake or something like that, with time, anxiety will begin to go down. And this can take place in a few minutes to just an hour or so. But it's almost invariably the response that if people, and you use your clinical skills to do this, can be enticed to remain very frightened and not escape, they'll feel better if they wait it out. And you're here with them and you're offering all your good clinical skills and support and reinforcement and unconditional positive regard and so forth. And you need to titrate the level of exposure. So at no point is it overwhelming to the client. And you always tell them, look, what we're doing at any point, you can ask me to stop, or we can back off the exposure and go back to a lesser level. So you're in control, but I will be encouraging you to try and confront your fear as much as possible. And I'll be with you the whole time. And I will never ask you to do anything that I won't do myself. So let's go on to the next slide. So in a course of exposure therapy, let's say we have an anxiety graph on the vertical axis and then time. If you're doing an exposure session, these usually should last an hour to 2 hours, longer if people can handle it. And you typically would see anxiety go up and up and up and up and up. And if they can continue to tolerate over time, let's say over 2 hours, it will gradually go back down, even though the amount of confrontation is still high. So you get that for a couple of, I love private practice, David. If you do this for a couple of sessions, then you're going to get in the subsequent sessions, the anxiety curves are going to be a little less peaked, a little less higher. They're going to diminish a little more quickly. And we take advantage of this naturally occurring process. It's something that nature has us do. We're sort of built in. And a lot of us overcome our fears this way on our own with any professional help. And the people who come to specialty clinics or for therapy are the folks for whom it's really, really a disabling condition for them. And I've known one patient with a severe fear of cockroaches. I did not treat her, thank goodness, but she was so distressed by her ongoing and pervasive fear of cockroaches that she killed herself. She was under the care of a psychiatrist. She was not clinically depressed, but her life was simply so miserable that she committed suicide. So don't think of these things as sort of like little quirky idiosyncrasies of folks. Oh, you're afraid of dogs, haha. It can be really disabling for people. It can result in them actually being practically housebound, for example, if it's a fear of dogs and there's dogs running around in somebody's neighborhood. Next slide, please. So in assessment, you'd want to make sure that the client meets the criteria for a specific phobia or whatever it is else you're diagnosing, social phobia and so forth, and rule out any exclusionary diagnoses such as OCD or schizophrenia or agoraphobia. Those more encompassing disorders would typically supersede a diagnosis of specific phobia. So if a person said they had a very severe fear of germs and they came because they couldn't open door handles or use public lavatories, if that was secondary to OCD and cleanliness preoccupations, you would use the diagnosis of OCD as opposed to a specific phobia. If a person comes for treatment and they're afraid of riding elevators, if you find out that that's a component of a larger condition called agoraphobia, you would treat them for fear of elevators, but you wouldn't give them the diagnosis of a specific phobia. You would use the broader term of agoraphobia. So you explain how you would propose to treat people with exposure therapy. I give them reading materials. I give them links to videos on YouTube and so forth. And I'd say, I'd like you to go home. I'd like you to really read this and watch these videos and come back in a week and let me know if this is something that you're willing to undertake with us here at the clinic. Yeah, I wrote a book, Kristen. This was a series that was edited by social work professor Charles Garvin. Some of you may have had him, and he recruited me to write this book on treating anxiety disorders. So it's very much in the client's control if they do this or not. And if they're unwilling to do real life exposure, it's almost always possible to nudge them in that direction. I had one client who just utterly refused to encounter a live snake. And I assured her, it'd be a harmless snake. It would be small. It would be in a terrarium with a locked top. And I would make sure it would not get loose. And she just absolutely refused it. I then suggested starting with a rubber snake. She refused that. I suggested pictures. or videos. She said, nope, nope, I don't want to see snakes at all. And where I finally got her to start is I had a cartoon of a snake. It was actually of the cartoon series Garfield. And it showed a snake with a very large object inside. It was supposed to be Garfield that the snake had swallowed. And I told her I have this cartoon. It's about 4 by 6 inches square. And what I could do is put it on my desk when you're out of the room, and then cover it with a postcard and index card. And you can sit down, and then with your consent, I would very slowly remove the postcard and just expose a tiny tip of the cartoon snake's tail, 1/8 of an inch or 1/4 of an inch or something like that. And there'll be no tricks or surprises. I won't suddenly spring it on you intact or anything like that. And she was finally willing to try that. So she left the room. I got the picture up, put it on my desk where she was sitting, cover it with an index card, asked her to come on back in, and we just chatted about it. And I asked her about her anxiety, just sitting there knowing there's that picture there that's covered up, and tried to diffuse that a little bit. And I said, can I put my finger on the top of the card? She agreed, and we just sat and waited that out because that made her a little anxious. And I said, can I scoot it over like 1/8 of an inch and show you the tip of the snake's tail? She agreed to that, but was adamant that I wouldn't do any more. And I said, no, no, absolutely not. I'm not going to do anything. I'm going to keep my word. And that's where we started. And from there, we just moved to 1/4 of an inch and then the whole thing after a session or so. And from pictures, we moved to videos, and then we used a rubber snake. And we eventually ended up with live snakes, even though she was adamant at the beginning that she was not willing to encounter live snakes whatsoever. So it's largely a function of your clinical expertise and being able to persuade people to give this a try. There's lots of reading materials out there, lots of good information on YouTube. And so share that information with the client. Just don't say, this is what I'm going to do for you. You ask them, you say, this is something I'm pretty sure that within a few sessions, we're going to know if it's going to be helpful for you. And if it is initially helpful, probably within a month or two, you'll be substantially over your specific phobia. And I tell them that, because it's largely true. And so that's where we begin. But the client has control over it. And if they're not willing to do something in real life, well, then you use some type of surrogate. And I'll say some more about that in a bit. Next slide, please. You need to determine more precisely the nature of the anxiety-evoking stimulus for the client. For example, a person could meet the DSM criteria for fear of dogs, and that'd be a specific phobia. But not all fears of dogs are alike. Some people are afraid of being bitten. Other people are afraid of the sound of barking, but really aren't that concerned about being bitten. Some people are fear of dog saliva or feces or dander or some other type of contamination. Smaller people might be afraid of being knocked down. Sometimes bigger dogs are much more fearful than smaller dogs. Does it matter what the breed is or the color of the dog or the hair? Because if you don't know exactly what it is about dogs that people are afraid of, you might miss the boat. And if you work with them for fear of being bitten when that's not what they're really afraid of, they're afraid of the sound of the dog barking, it won't work very well. You've got to figure out exactly what it is and work with desensitizing the person to that. And the sound of barking, that's relatively easy to recreate. You can go on YouTube or anywhere else and just type in soundtrack of dogs barking. And you can get, all kinds of resources like that. And the client can practice listening to it on a very, very low volume to start with. And they can control the volume, not you. And after they listen to a particular level for a few minutes, ask them if they could increase the volume a little bit just themselves. So if they had a fear of barking and you treated them for fear of dogs, or you think that it's related to dog saliva or something like that, you won't really be providing optimal therapy for the person. Next slide, please. Sometimes what looks like a specific phobia is actually secondary to a primary or more fundamental disorder. Somebody with fear of going to the barbershop may actually be a manifestation of having panic attacks, or somebody with fear of grocery shopping or going to the bank. Those are all situations where once you enter them, it's very difficult to leave quickly. When you're checking out your groceries, once the clerk is halfway through, you just can't leave the store if you have a panic attack. So people may fear lots of things for fear of having a panic attack in that situation. And the proper diagnosis would be panic disorder, not a specific phobia. Similarly, a fear of shaking hands may be the most predominant feature of somebody, but if they have a OCD-related fear of germs and washing and cleaning, the OCD diagnosis would trump the diagnosis of a specific phobia. Next slide, please. So it's very important to get the diagnosis right and then get the specifics of the anxiety-evoking stimulus that particularly troubles the person. Next slide. So in real-life exposure therapy, guess what? We try and get real life, dogs and cats and snakes and spiders and so forth. You need to locate convenient elevators, high spaces, small enclosed places, safe places to drive, and so forth, because real life exposure therapy takes place in real life. And it's an unwarranted assumption to think that you've got to do cognitive exposure first or exposure in imagination first. Most people can tolerate it in real life if you just titrate the intensity and don't have any tricks or surprises. If real life recreation of the anxiety evoking stimuli can't be undertaken, like thunderstorms, or the client refuses any real life contact with it, then videos, pictures, toy objects, and so forth. And increasingly now we're seeing exposure therapy being conducted in real life because people say, oh, it's too inconvenient to recreate real life settings, and I can do it in imagination with the virtual reality technology. That's true, but at some point, when you're using exposure and imagination or in virtual reality, you got to make the transition to real life, because people aren't afraid of imaginary dogs or dogs that they watch on virtual reality. What they're really afraid of is dogs in real life. So things like imaginal exposure or virtual reality are basically truly unnecessary if you can recreate in some way the real life anxiety evoking situation. Next slide, please. So when I'm working with somebody with a specific phobia, I like to do a formal assessment of the severity of their fear. I ask them to rate their anxiety on a scale of 0 to 100, meaning no panic at all to extreme panic, when they're some distance away from what they're afraid of. So if I would have a small dog on a leash tied across the room and it can't get away, and I would ask the client to look at the dog from 20 feet, and to rate their anxiety. Then, if possible, I also have them wear a little heart rate monitor, the kind of thing that clips on the end of your fingertip. And when they say what their anxiety is, well, looking at the dog from 20 feet away, I look at the heart rate monitor. So I write down how fearful they say they're feeling, how far away they are, and then their heart rate. Then if I'm 20 feet away, I move a couple feet closer and I ask them, can you join me 2 feet closer? And usually with a little coaxing, they can. And you repeat the process. And at some point, the client says, I can't get any closer. Maybe 6 feet away, it may be 10 feet away, it might be right next to it. But at some point, that's a measure of behavior. So if you do this before you begin an exposure therapy session, you've got to measure the client's behavioral avoidance, you got to measure their subjective anxiety, and you got to measure their heart rate while they're confronting what they're afraid of. So then you actually do the exposure for your session. Can we have the next slide, please? And here's an example of a real life case. And on this graph, I have two things graphed. The solid squares represents the client heart rate, and the triangles represents subjective units of distress, 0 to 100 of anxiety. So in this particular client, you can see that when she was out of the room from what she was afraid of, and what she was afraid of actually was balloons, her subjective anxiety was around 20%, and her heart rate was around 65. She was a real athlete, by the way. When I opened the door and asked her to come into the room and actually see the balloon on the floor 20 feet away, her anxiety went up a little bit, and her heart rate didn't change much. Then when she got closer, you can see it bumped up, and I asked her to come closer and closer. And finally, when she was right next to it, she said, I can't get any closer. I can't touch it or anything. And this is as close as I could get. So this little graph depicts my client's phobic avoidance, quantified, subjective, behavioral, heart rate, before I formally began treatment. I saw the chat question go up. Are there risks for this? And there's really not. As a psychotherapy, it's got the same level of acceptance as verbal therapies. And although we might think, though, my gosh, people would be at risk for having a heart attack or stroke or something like that, or fly into a panic and run screaming from the room. I've never heard of that happening. I haven't read it anywhere in the literature, and it certainly has never happened in any of the clients that I've worked with, believe it or not. So you have a graph here, and this is a client with a specific phobia. In this case, she was afraid of balloons. And then I began to treat her. The next slide, please. And we did a variety of things, and it was all done with her consent. I proposed an initial level of exposure and asked the client to encounter it. In this case, it was I had a bag of empty balloons. She hated balloons. She didn't even like deflated balloons. So I get her to sit with me, and I've got a bag of balloons, and she knew this. And I asked, can I bring it out? Can we look at it? And then I asked her to hold it, open it up, and then see if she could blow it up a little bit. And the more she blew the balloon up, the more frightened she got. So we just practiced this. And honestly, within an hour, she's blowing up a balloon, and she's much more comfortable about it. She's sort of laughing and screeching at the same time. And I'm using praise and reinforcing, and I'm role modeling and so forth. Then we would transition from blowing up balloons full to blow it up just a bit and then prick it with a needle. So it made hardly any noise at all. Then we blow the balloon up a little more and prick it, a little more and prick it. So we practice this in real life. And then we also did some sessions by Zoom. She was in New Orleans. I was here in my office, and we did the sound of the popping balloon by having her have her volume down very, very low while she watched me pop big balloons. And I just repeated this, and I asked her to turn up her volume until she could do it herself. And then while I was watching, to blow it up a little bit and prick it, and blow it up a little more and prick it. So we had a couple of sessions like this, an hour or two each time. And I gave her homework to do. I said, put blown up balloons around your apartment, carry an empty balloon in your purse, maximize the amount of daily exposure you get. And every day practice blowing up balloons and popping them now that you're able to do this with me. And she was able to do this by going slow. And if she hadn't been able to do it, I would have stepped in and tried to help her. So you provide reinforcements, support, reassurance. Every so often ask about their anxiety level, ask them what they notice descriptively about what it is they're afraid of. So if they're watching a snake, I ask them, what do you think the snake feels like? They would say, oh, the snake would be slimy, which they're not. Is the snake making any noise? What's the snake doing? And they would comment on the snake flicking its tongue out or moving its tail back and forth. And this is all a way to engage them with exposure. And no, the Zoom, I saw the chat question, the Zoom exposure was not done because of COVID. It was because the client and I were in different cities. She was in New Orleans and I was in Tallahassee. So you're asking, what are you feeling? Sometimes people get little paresthesias, unusual sensations or tingling or something like that. That's pretty rare, but it sometimes happens. It might be secondary to hyperventilation. And these things all pass. The horrible thoughts, the feelings, they eventually catch up when they eventually get to the point where they're touching what they're afraid of, and they learn the snake is not slimy, the dog will not bite, and so forth. So we start slow, and you just move the client ahead as much as they're willing to tolerate, but not more than that. Always provide assurance that there's no tricks or surprises. We have the next slide. With time, anxiety will subside. When appropriate, encourage a closer level of contact. Tears and shaking and so forth are common. These will subside. These are not a reason to stop. As long as the client's willing to continue, even though they're crying, their anxiety will go away. And if you do this for a couple of hours, time your exposure so that they've encountered one level and they're pretty calm, and that's when you want to stop. You don't want to start when you introduce a new high level of exposure and leaves them very frightened and say, okay, time's up, we're going to stop now. You want them to stop when they're feeling really good. Then you get rid of what it is they're afraid of and just spend some time processing the experience. Schedule your next session. Sessions closer together are better than sessions spread apart. Longer sessions are better than shorter sessions. Sometimes the clients will have dreams about what it is they're afraid of. These will subside. They're not necessarily scary, and they're just sort of something to be expected, like any other intense experience. I've been on roller coasters at theme parks and then had a dream about being on a roller coaster the next night. It's sort of along that type of process. Can we have the next slide, please? Now, when they come back, expect some regression from the gains made in earlier session, but these will usually be quickly regained and continue as before. And what you're looking for is not simply a reduction in avoidance behavior where they're, let's say, touching the dog, but if they're gritting their teeth and their heart rate's still high, that's not good. So what you want to do is continue the exposure so that eventually their heart rate slows down and their feelings catch up to their changes in behavior. And usually it works along the lines of you get behavioral improvement first, but they're still afraid and rapid heart rate. Then slowly the feelings begin to catch up and they tell you, oh, it's not as high anymore. It's 30, not 50. And then when they're encountering what they're afraid of and they're no longer feeling subjective fear, then the heart rate typically catches up. And it's a very reliable technique if you can just be patient enough to give it a try. Next slide, please. As appropriate, move from office-based exposure to more naturalistically based settings. I would work with my client in an office, let's say with a snake or a puppy, and then at some point we'd go outside. And in the case of a snake, I'd find a grassy area, and she had practiced learning to pick up a snake in my office. Well, now we try it in the grass, which is more naturalistic. So I would have her turn her back and I would walk away and put the snake in the grass and ask her to turn around. And I say, okay, between here and the tree is the stake. I want you to get it, find it, pick it up and put it in the bag, just like you did when you're in my office. And I'm there and I'm coaxing and I'm reinforcing and encouraging. So this is a more of a person and environment type of therapy where you're just not doing consulting room sessions, where you're actually having the client get into contact in real life settings. Obviously, somebody with fear of driving, you go driving with them. I've gone flying with renting a plane and a pilot, a small plane, at the airports in Ann Arbor with clients who had a very severe fear of flying. And when you can, overtrain, go beyond normal. Because if you train somebody, let's say, who's afraid of dogs and they're okay with a beagle, let's say, which is not a very frightening animal, if they get all over that level of fear, if they then should encounter a barking German Shepherd later on, after they've concluded treatment, they're more likely to relapse than if in the actual context of treatment, you've got them over being around several large, big barking dogs. If they can handle that, it's much less likely that they're going to relapse. And this is not done out of cruelty. It's to try and reduce the likelihood of relapse and the durability of the gains that people have made. Next slide, please. Then assign homework, either by themselves or let's say if you work with them in a park that had a lot of bees, and the person was afraid of bees, and you're standing there with them surrounded by bees in the spring as a part of the desensitization exercise, have them see if they can go back by themselves or perhaps with a family member without you. And this enhances generalizability and maintenance of improvements. Involve family members as appropriate, and you just continue this until functional limitations are eliminated. Subjective anxiety is markedly reduced, and the client tells you they've achieved what they sought, freedom from their phobia. And actually, people can often make many more gains working without you after you've shown them what to do and how to do it. Asking them to go out and do it themselves be a little scarier, but if you've done good solid work with the client, they should be able to back off a little bit and recreate their phobic situations in real life. And you just need to be clever about it. Figure out how you get access to a dog or a cat. I had a regular relationship with the pet store in Ann Arbor, and I would come and I would borrow a snake, and I told them what it was for, and they respected that, and they were very helpful in letting me do that. I found a source for frogs and spiders and birds, And it's a little time consuming, but that's what we did. We helped people and we did whatever it took to try and get them over their fear. Next slide, please. So here's our second monitoring question. Encouraging the client to engage in real life homework practice is an important part of exposure therapy, true or false? Okay, can we close the poll? Very good. Either I'm really a good teacher or you guys are really smart. Okay, next slide, please. Now, in the lady that I was treating for the fear of balloons, this represents her phobic avoidance when treatment was over. Exact same thing. I started with the client out of the room. She can't see an inflated balloon against the wall in the other room. And you can see that when she's out of the room and I ask her what's her anxiety level, she gives me a 0 and her heart rate is, in the low 50s. Like I say, she was a real jock. Then come into the room, look at it 20 feet away. It was still 0, 15 feet away, 10 feet away, 0, 0. Then 5 feet away, her anxiety began to go up a bit, heart rate increased. And then she got to the point right next to the balloon, then tapping the balloon, touching the balloon, and then holding the balloon in her palm or holding it against her face. That was like basically unlimited contact. You can see her anxiety you can see her heart rate went up towards the end, but she was able to do all these things with minimal levels of anxiety. So I capture 3 dimensions of what we could call a phobia here: the behavioral avoidance, the subjective anxiety, and the heart rate. So you don't have to do these behavioral approach tests pre and post treatment, but they're a nice way to sort of quantify what's going on and show the client, show your supervisor, show your students or your supervisees that this is what you get, what you can get when you treat people with real life exposure. Next slide, please. So once they're discharged, follow them up, check out to see how they're doing. Usually gains are pretty well maintained. Next slide, please. If they're not maintained, then you just retreat them. It doesn't mean the treatment didn't work. It just means they need a few more booster sessions or something like that. I know you're all chomping at the bit to see this in action. So let me see if, Emma, you can go on that lower link that says snake phobia 12 minutes, the green line right above that, and click on that and see if we can get this YouTube to open up. There might be a little advertisement at the beginning of the YouTube, but this is really a good 12-minute shortened video of real life exposure with a real person. So hang on here. If you're afraid of snakes, you may not want to watch this. That type of response was not atypical. It lasted, I'm not sure how long, an hour or two, and you saw the rather dramatic improvements she's made. At one point, she's both laughing and sort of being very anxious at the same time. And she made remarkable progress. Emma, could you go ahead and advance to slide number 48? Okay. Some nuances in conducting exposure therapy. You got to try and work to remove subtle avoidance behavior. Like at some point you saw the woman was avoiding her eyes and her face and her body. She was turned at an angle. As she calms down, you ask her to sit facing the snake, to continue to look at it. Don't avert your face. Don't put your hands over your face, that type of thing. Don't interpose things between you and what you're afraid of. Sometimes people have things they like to carry around, placebo-like objects, things like a bottle of Valium. And they think that if they get really scared, they can take the Valium and that'll make them feel better. And it will, but you need to be able to walk around in life without carrying benzodiazepines to function. Obviously, modeling, the therapist role modeling, whatever they're asking the client to do and being calm and not being distressed overly so when the client expresses that they're upset. Use lots of reinforcement for increases in approach. and reductions in avoidance, verbally with adults and kids. Maybe you can add some tangible reinforcers when you're working with kids. Shaping is very much a part of exposure work. You wouldn't do a big jump from being terrified 20 feet away to holding the snake at the next step. It'd be very gradual. And then you do the overtraining, as I alluded to try and enhance maintenance and generalization. Next slide, please. Some options to real life. You can do exposure and imagination. I had a patient who was faced with a vacation to the Caribbean very soon, and she didn't have time for real life fear of flying. So we did exposure and imagination with her just in the office, and that seemed to work reasonably well. She sent me a postcard from her Caribbean hotspot and had a good time, and the trip went well. Narrative exposure therapy is another variation. This is where people simply talk about their anxiety-evoking stimulus or their trauma or their PTSD anxiety-evoking situation. They write about it. They listen to stories about it. You can use virtual reality. But just keep in mind that when we're creating anxiety-evoking stimuli is not possible or not tolerated by a client, remember they're not primarily afraid of imaginary things. They're afraid of real things. So at some point, we should segue treatment into real-life situations, which again makes this a person and environment type of therapy. Next slide, please. There's a bunch of treatments out there that don't work very well. All those very tapping therapies and energy therapies that are so popular, things like neurolinguistic programming, conventionally oriented, insight-oriented psychotherapy, supportive treatment, hypnosis. Medications provide relief, but no cure. People will be less anxious when they're on a benzodiazepine or other anti-anxiety agent, but it wears off, which they all do. The fear will still be there. Medicine is more like insulin for diabetics. It's not a cure. Exposure therapy is not a cure, is curative, whereas insulin is not. It's a treatment. So something like supportive psychotherapy, people will feel supported, but it's not going to produce substantial benefits. And hypnosis is completely worthless with this, above and beyond placebo. Next slide, please. Next slide. Social phobia. This is very common, and it's usually centered around fear of public speaking, musical performances, using public lavatories where you're making noise, the sound of urinating or other noises. Some people simply cannot use public lavatories, and that's a social phobia because it occurs in a public setting. And people fear they're going to act in a way that will be negatively evaluating by others, will be humiliating or embarrassing, and others might reject you or offend you in some way. Next slide, please. The social situations almost always provoke anxiety or severe fear. If they have to do the social situation, it's endured with intense fear of anxiety. For example, students in my class who don't like to be called upon, they do it, but they don't like it. They're very unhappy. And the fear of anxiety is out of proportion to the actual threat imposed by the social situation and the context. And again, the social phobia features have to last 6 months or more. Next slide. Causes impairment, and it's not due to other problems or another disorder. Next slide, please. So with social phobia, confirm the diagnosis, take a history, try and figure out onset and any apparently precipitating events, ask them how the client copes, look for exceptions. You can borrow from our friends, the solution-focused people, ask them where there are times there are not anxious. For example, an adult who has severe public speaking phobia, if you ask them, they might say, well, you know, if I was speaking to a class of kindergartners, I wouldn't have any anxiety at all. It's only when I'm talking to other adults that I'm fearful. So you want to try and get those details nailed down. Next slide, please. See if you can recreate it in real life. Explain how you're going to recreate it and emphasize the client will set the pace. No tricks or surprises, and they can back off on the exposure at any point. Give them reading materials and videos to watch and arrange for the first session. For example, with public speaking phobia, I would videotape the client and ask them if they'd be willing to give a short speech, let's say 2 or 3 minutes, just to me alone in my office. And if they had anxiety with that, it would probably be rapidly overcome with practice. When they make their speech, I have them watch themselves because people feel very nervous and they think it's obvious or conspicuous to an outside observer, but it's usually not. They may feel like they're shaking inside, but if they see a video of themselves and they don't see any tremoring, they don't see excessive amount of stammering and so forth, that by itself can help break up any misunderstandings about what it looks like when they're very socially fearful. When they can give a comfortable speech to me, I will try and bring in staff and have them give speeches to a small number of people. I've had clients come to my classes, like I'd have a class of 30 students and they would work with me. And the client would give a 2-minute speech to one student. And if it went okay, I brought in a couple more. And if I went okay, I brought in a couple more. And then pretty soon they're giving the same 2 or 3 minute speech to 30 people. And to exaggerate the effect, I have them give a speech like they were Mussolini, pounding on the podium, for example, using hand gestures, using a loud voice, and to sort of overtrain the getting rid of the fear of public speaking. Another slide, please. Next slide. Next slide. One really good resource that I found is an organization called Toastmasters International. It's very low cost. You join them, and it's a group of people who want to improve their public speaking fears. And they have a 10 exercise workbook, and you attend the sessions and you listen to other people give speeches in this workbook, you know, the first speech, the second speech, and they gradually increase in complexity. And at some point, the client, by attending Toastmasters on a regular basis, the facilitator will ask them if they're willing to try their first talk next week. And at some point, the client will agree, and then they're off and running. They get lots of reinforcement from other people in a non-judgmental environment. And the 10 exercises in the workbook gradually escalate and become less structured and more open and free-flowing and longer. And it's really a built-in self-desensitization program that's very, very low cost. And I often would take a client to a Toastmasters session to have them see what it's like, and then encourage them to go on to it from there. Next slide, please. I'm gonna, in the interest of time, I got to skip OCD here. Another slide, another slide. One more, because I want to last one more. Keep going, one more. Okay, here's a monitoring question. Don't worry if you get this wrong, because I didn't really cover it. Most people with OCD present primarily with obsession as their dominant difficulty. Go ahead and make your vote. Okay, let's wrap up the poll. Okay, actually, it's relatively rare for a purely obsessional person to present. It's usually rituals and compulsive rituals and obsessions, and then rituals alone with obsessions by themselves, relatively rare. Let's go to the next slide. And Emma, there's a video here. It's about 6 minutes long by one of the country's leading experts on exposure, Barbara Rothman. She's going to talk about some myths of exposure therapy. So at this point, we have a few minutes, and I'd be very happy to entertain some questions you may want to pose. And I gather Emma wants to moderate this as opposed to people speaking. So Emma, you were going to pick some questions to ask me?
Yeah, we actually have gotten quite a few questions, and I'm glad you went in and answered some of them while we were watching those videos. People are very interested in this topic. So the first one I'm going to ask, can you share strategies for working with young children with selective mutism?
Yeah. When people get my PowerPoint deck, they'll see a couple of videos in there about using exposure therapy with young people. You wouldn't want to use anything developmentally inappropriate. You'd want to go slowly. In particular, you might want to make more use of tangible reinforcers when you're trying to encourage the child to engage in some type of encounter with what they're afraid of. But the procedures are exactly the same. You just go slower, and you can have parents observe if that would comfort the child. Um, but usually, if a child has a fear of something, dogs or cats or snakes or something like that, it can be pretty readily resolved. Even things like injections can be treated with this approach. Fear of injections.
Kind of building off of that one, because I would assume that this next question would be more relevant for, well, I guess there could be college students as well. But what are the implications in the educational setting for individuals with school phobia or school avoidance?
Well, there's a huge literature on this, and there's a lot of evidence-based interventions that have been developed. And with what looks like school phobia, you need to ascertain what's really going on. So if the person says they're afraid of the school and that's why they're not going, try and figure out what it is exactly. If the person's afraid of being called on in class, that could make them look like school phobic, but it's really the fear of being called on in class. If there's a bully in the school, they may be afraid of being bullied and superficially look like school phobia, but it's not. It's a fear of bullying. If there's something on in the family life, let's say abusive situation between the parents, the child may want to stay home to protect the victim. So what looks like super social phobia, I'm sorry, school phobia really needs to be carefully looked at to make sure you've got the diagnosis correct. And if whoever wanted to ask that question, if you'll email me privately, my email's on the first slide. I can give you some references to the treatment of school phobia, but you would use it pretty much the same way. Jennifer Howard asked, why is the therapist not guiding her through
Yeah.
breathing exercises? It's because it's not necessary. Breathing exercises are just an elaborate placebo here. You don't need to do it. People will make just as much progress as without breathing exercises. So why introduce that additional bells and whistles?
Yeah. Um, will this approach or would this approach work with hoarding clients?
Oh, yeah. One of the country's leading clinical researchers on the treatment of hoarding is a social worker named Gail Steketee. She was the former dean at Boston University. She literally wrote the book on exposure therapy, response prevention to treat PTSD, to treat hoarding, and to treat OCD. And she's got some excellent books on this topic. And if you were to look up Gail Steketee on Amazon or something like that, you'll see some of her publications related to the treatment of hoarding using exposure. What are people afraid of? Getting rid of stuff. How do you treat it? That you work with them to get rid of stuff, and you start out with small stuff and you move up to big and more important stuff over time.
How do you conduct the behavioral approach test via telehealth?
Um, for one thing, I could simply forego it. It's not a requirement that you do it. It's just a way of measuring effects in a more rigorous way than clinical impression. Um, if you might have an assistant, like if your patient has got a friend, you could recruit the friend to bring a dog to the room, and you can see it on camera, and you sort of guide the client through it that way. Um, but if it's just the client by themselves, might be a little more difficult to do that, in which case I wouldn't do it.
Thank you. Another good question. How is this therapy funded? I can't imagine insurance companies would pay for this level of care.
They did at Michigan.
Nice. Wondering about the after effects for social anxiety. A lot of my clients can get themselves through a social situation, but overthink the interaction after.
Yeah. Um, well, once they're over the phobia, they won't overthink the interaction anymore.
Mm.
That's the beauty about it. You continue treatment till you see behavioral improvement, improvement in subjective feelings, and improvement in things like rapid heart rate. Let,
Do
let them overthink it. Just with repeated practice, it'll get better.
And I do just want to add, we will end at 1:30. However, if Bruce wants to take some more questions, we can stay a little bit longer. But if you need to leave at 1:30, you will get all of your continuing education hours. I know folks are worried about that. Um, I thought this question was interesting. Do the statistics strongly support that this is better treatment for EMDR? That is what I'm taking from this presentation. The information is great, they said.
Absolutely right. EMDR is basically watered down cognitive therapy, where the person is confronting what they're afraid of in imagination. And it's been clearly shown, and I'm not just making this up, that the eye movements have nothing to do with the success of EMDR. This has been looked at. They found other things can work with eye movements like tapping or holding vibrating cans or something like that bilaterally. Um, uh, the research on EMDR, it's a good treatment. It's modestly effective, but at some point, the person has got to encounter in real life what they're being treated for with EMDR.
Interesting. How much time needs to be given between a traumatic event and starting exposure therapy?
Well, the DSM certainly has a time limit. You have to have the problem for a certain amount of time before it's a diagnosable condition. I don't really know whether it matters, but obviously, if somebody was in a horrible car accident last week and they're okay now, it might not be the good time a week later to start treating them for their fear of driving. I would let some time go by and see how much of it resolves on its own. I don't know of any data to answer the question apart from that.
Would liability insurance need to be factored into doing this work? How do you account for liability out in public? That is such an interesting question.
It's a very important question, but social workers have been going out in public with people all the time. Um, I would think that this is a recognized treatment. It's research supported. And if you're doing what's supported by the research to help somebody, I don't think you're in particular liability for that. And now maybe if you're asking, what if you have a car accident while the person's practicing their driving phobia or something like that? All I can say, this has never happened. And if you're unwilling to tolerate that yourself, don't do it.
Yeah, that's fair. All right, we'll do two more questions and then we will call it. So Hoda says, will patients develop another phobia after working through a specific phobia?
Absolutely not. That's been extensively researched. And we've known for decades now that what Freud called symptom substitution is not a side effect of real life exposure therapy.
Nice. And last question we're going to do, how does exposure therapy relate to distress tolerance?
Um, Obviously, you can only proceed as fast as the client is willing to permit. And if they have a low distress tolerance, you go slowly. And if they have a high one and they're willing to sit there and weep and shake and still encounter what it is at an intense level, you move ahead with that, because that will get the problem over with as quickly as possible. But you never will overwhelm the client deliberately, and you take good steps to make sure you don't do it inadvertently. And if they want to go slow, then you just go slow.
Great. Well, thank
It
you so much, Bruce.
looks like this is over. I want to thank everybody for attending. Hope you found it enjoyable. And if you want to email me with other questions or need some citations or something, feel free to do that. This is what I do.
Thank you so much, Bruce, and thank you everybody for joining us. That was a really wonderful presentation. And again, if you are here to receive your continuing education hours, if you have any questions about that, please contact our continuing education office. Their email address is on the screen. I also encourage you to visit our webpage featuring all of the different events happening for Social Work Month. Have a wonderful rest of your day. Have a great weekend, and thank you so much, Bruce.